A middle-aged lady had a fall and then after sustained a left hand injury. Overnight, she noted swelling in the left hand, which was treated with ice and ibuprofen. She complained with left hand pain, denies any paresthesia or paralysis of the hand. On assessment, there is swelling and tenderness, but the skin is intact over the fourth and fifth metacarpal. Range of motion of the fourth and fifth metacarpal is limited, with limited secondary to pain. Distal neurovascular system is intact. No collateral ligament instability is appreciated. While going on the differentials, there can be a fracture which can be intra-articular, extra-articular, or a sprain. An X-ray was done which reveals a shear type fractures with displacement of the fifth and the fourth metacarpal head. Metacarpal fractures are rare fractures. It has been classified by McElfresh and Dobyns into different type of patterns. There are specifically 10 anatomical patterns. One is epiphyseal. 2 is collateral ligament avulsion injuries. 3 is osteochondral injuries. 4 are oblique injuries. 5 are vertical injuries. 6 are horizontal injuries or transverse injuries. 7 is comminuted injury. 8 is an intra-articular extension with a boxer fracture. 9 is a loss of substance injury. 10 is avascular necrosis. Of all these, comminuted fractures are more common. That is 31%. In our situation, there was a lot of comminution. And the A&E ulnar gutter splint was applied and he was prepared for surgery. A surgery was on the next day. A plan of open interstitial fixation of the left metacarpal head as well as fourth metacarpal head was performed. Using fluoroscopy, the hand was examined and revealed displacement in the fifth metacarpal with comminution of metacarpal neck. The fourth metacarpal head fracture appeared non-displaced compared to the fifth metacarpal. The patient was given auxiliary anesthesia and an upper arm tourniquet was applied. A curvilinear incision was made over the metacarpal joint on the left fifth finger. The skin was incised and the flaps were created. Extensor tendons were mobilized by excising portion of the sagittal band. The capsule was incised, hematoma was irrigated. Under direct revision, an open reduction was performed. Due to the comminution, the fracture needs to be held by 2 transverse K-wires of 0.035 inch and cut off subcutaneously. An additional longitudinal 0.035 inch K-wire was introduced through the metacarpal down the shaft, reducing and maintaining the metacarpal head onto the metacarpal shaft. The wires was also cut subcutaneously. The wounds were irrigated and the capsule and skin was closed. The patient was placed in a short arm cast, incorporating the ring and the small finger. While talking about the internal fixation, there are several techniques depending on the pattern of the fracture and the fragment size. The goal is to provide some secure enough stability to allow early range of motion. KOs, while although popular and effective in maintaining the position of the small fragments in a static state, are not quite efficient in early mobilization. The placement of K-wire ends must be considered not to interfere with the extensor tendon excursion. Intraosseous wire can provide secure fixation of the fragments while interfering minimally with the soft tissue excursion. Absorbable pins are also in some instances helpful. Osteochondral metacarpal head fractures in particular are amenable to absorbable pin fixation. With large enough fragment, screw fixation is also possible. The mini screws such as Herbert screws or Ecotrax screw system, which can sunk beneath the chondral surface, have added significance in fracture fixation. Comminuted fractures with displacement of the head and the shaft require plate fixation for sufficient stability. The synthesis Mini-condylar plate used as a buttress provide adequate stability to support the articular fragments. The cancellous bone graft from the distal radius or the proximal ulna can be used for chondral support. Collateral ligament avulsions fractures greater than 20% of the articular surface should be treated by open ductal fixation. The open injury is usually fight, bite, necessitate wound, excision, debridement, and copious irrigation, with some authors recommending delaying fixation until second exploration is done. Postoperatively, 10 days postoperatively, the patient cast was changed. Radiograph reveals stable fixation. 3 weeks post-op, the longitudinal pin is removed and other splint is continued. After 1 month, the transverse pins are also removed. The patient is instructed to begin gentle range of motion exercise with progression in function. Patient progressed with acceptable range of motion with the hand therapist, and radiograph revealed later on excellent alignment of the fractures. While this was our method of fixation, there are alternate methods as well. The majority of the metacarpal head fractures sadly are treated by the non-surgical means. 2/3 of these fractures are treated by close. Of these treated operatively, more than 67% had open fracture necessitating fixation. Extensive convergent metacarpal head fracture that are untreatable before internal fixation and that would reasonably return congruence to the articular surface accompanied by stability adequate to allow early range of motion are best treated with close methods. The fracture can be treated using principles of brief immobilization followed by active protective motion. Collateral ligament avulsion fractures comprising less than 20% of articular surface can be treated by protected immobilization for 1 week, followed by body tapping for adjacent digits for another 6 weeks. As a side effect or complications, the most common notable is reduced range of motion as the articular surface is non-congruent. The ability can loop the frequently can cause loss of motion and degenerative arthritis of metacarpophalangeal joint. Infection is rare with close injuries but a significant concern with open injuries. And meticulous soft tissue management and prophylactic antibiotics are required in that situation. Avascular necrosis of the metacarpal head and fracture fragment is extremely rare and can be minimized by minimizing soft tissue stripping around the fracture fragments.